mRNA-based ER testing. What could this mean? I'm going to try to use the... Good. Here is a series of 18 breast cancers, IHC 20% or more, so very robust IHC positive. Notice the mRNAs vary. You got some very high ones, like these 5, and maybe some fairly low ones, these 5. These 5 are HER2 positive. HER2 positive breast cancers that are also ER positive, mostly the so-called luminal Bs, will have a much lower mRNA for ER than HER2 negative ER positives. What that means for therapy selection is highly controversial. There was a little movement, maybe 4 or 5 years ago, to use HER2 status to decide whether to use an aromatase inhibitor up front despite menopausal status and skip tamoxifen or not. The gun trial in Italy said tamoxifen made ER positive, HER2 positive breast cancer worse. You got more recurrences when you treated than if you used nothing, placebo. American oncologists don't believe the Italian data and don't think HER2 positivity is a contraindication for using tamoxifen in ER positive patients. And there's no data that would so far exist to prove that using aromatase inhibitor up front gets a better outcome. That's not proven. So there might be a point where HER2 status drove ER therapy decision, but it's certainly not commonplace now. On the other hand, I'm intrigued by this, like these 2 cases and maybe this one, where the mRNA is so very high. mRNA is a more signal-driven test than IHC. mRNA-based testing has a high dynamic range, a big grayscale. You, in other words, have white transitioning to black with lots of shades of gray in between. But IHC was designed to be very, very black, and then when enough protein was present for the marker to become completely visible, with not a lot of intermediate in between. For that reason, it's not maybe as easy to tell a 20% positive ER that has very high message from a 20% positive ER on protein-based that has a low. Why would we want to know? Because it may someday be that high mRNA expressing breast cancer is so dependent upon the ER pathway for the drive of the tumor progression that even in a node-positive status, it doesn't require cytotoxic therapy and should be on hormonal therapy only, which, of course, right now would be against current common practice, that node-positive breast cancer receives adjuvant cytotoxic therapy, regardless of the ER status. Well, we may be able to pick, and there's been some arguments, maybe 5%, maybe 10 of the node-positive, ER-positive tumors that we could pick out and spare the patient the cytotoxic agents. Maybe the Oncotype test on node positive will be capable of doing this because it's going to measure mRNA, and we'll see later that that's the most important mRNA in the algorithm. And we'll customize the treatment for metastatic disease, node positive, and avoid cytotoxic therapy, which is thought not to have any efficacy in this particular subset of ER positive disease.